Hi, my name is Mia Bevilacqua. It is November 4th, 2022, and I will be covering Case Connections Part 4, and I will be covering questions number 1 and 2. I'm not going to run through reading the questions because it takes too much time, so you'll only hear my answers to these questions. For the first question, ammonia transfer is a mechanism that works to get rid of nitrogen in the body using the urea cycle, as we've learned in from Dr. LeClaire throughout Chapter 13 in lectures and in study guides. In a properly functioning body, amino acids will be present in the muscle and as well as other types of tissues, and through a series of reactions, these amino acids will transfer nitrogen to the liver to enter the urea cycle. So in most tissues, the amino acid glutamate is present, and we'll go through a reaction using glutamine synthetase, which will act to fix free ammonia as glutamine so it can be transported from those tissues and out of those tissues into the liver. And then upon entrance into the liver, glutamate undergoes a reaction through glutaminase, and that reaction releases the ammonia that glutamate is holding and produces glutamate and free ammonia that is then sent out into the urea cycle to later be excreted from the body. And the glutamate that is left in the liver undergoes a reaction through glutamate dehydrogenase, otherwise known as GDH. I will be referring to it as GDH from now on. And glutamate dehydrogenase frees any remaining ammonia group and can send that ammonia group out into the urea cycle. This reaction leaves us with the product alpha-ketoglutarate. So this keto acid can do two things. It can either enter the TCA cycle as a substrate for glucose or fatty acid synthesis, or it can undergo transamination with alanine to transfer nitrogen that's being held in alanine to glutamate while also producing the keto acid pyruvate. So this all sounds familiar. Alanine comes from a product of reactions that actually occurs in the muscle tissue. So glutamate found inside the muscle tissue undergoes a transamination reaction with pyruvate to transfer the nitrogen from glutamate to produce alanine, which is able to be transferred out of the muscle tissues and sent into the liver. And once alanine is in the liver, it can undergo another transamination reaction with alpha-ketoglutarate to produce two products, and one of those products is pyruvate. So we know that pyruvate can be sent through the TCA cycle or gluconeogenesis, where it can be converted into glucose and used for energy. And glutamate is the second product of that transamination reaction and can be recycled and use GDH to release its free ammonia again into the urea cycle and be excreted from the body. So, in my opinion, this newborn's body may have a deficiency that affects the excretion of ammonia through the urea cycle due to the blood ammonia levels being so high. Dr. LeClaire also explained through presentations and study guides that in the fasted state, alanine and glutamine are dispersed throughout tissues via cortisol-mediated protein catabolism. Gluconeogenesis is directly related to nitrogen transport because amino acids such as alanine and glutamine supply substrates for both of those pathways. Amino acids contain nitrogen and are used through a series of transamination reactions to carry the nitrogen in amino acids from tissues like muscle to the urea cycle, as we had just went over. Through these transamination reactions, pyruvate is often produced, which can be used as a substrate in gluconeogenesis. And to add on to that, gluconeogenesis also uses free amino acids as substrates in its pathway. So really in a fasted state, when glucose stores are really low, the body can use these amino acids as a substrate in gluconeogenesis in order to produce energy. And then for the third part of this case, this is my answer. The urea cycle is a chain of reactions that are used to eventually excrete urea from the body, while orotic acid or orotate is not directly part of the urea cycle affects its concentrations. So orotate comes from a pathway that accepts excess carbamoyl phosphate, which is a product of the first step of the urea cycle. So when carbamoyl phosphate isn't being used in the urea cycle, it builds up and it can increase the synthesis of that shunted pathway and increase the synthesis of orotate, which will show as high orotic acid levels on blood panels, as we see in this patient. This means that the process that produces carbamoyl phosphate is active and it is working, which means that the first step of the urea cycle in this patient is working. But plasma citrulline levels are on the lower end of normal. The normal range is above 12 to 55. And this patient has citrulline levels of 10, which is just under the lowest mark for normal. So this means that the second step in the urea cycle is functioning, but it may not be functioning to its full capacity, and it may be functioning at a slower rate. And due to the fact that orotate levels are high, meaning that there's carbamoyl phosphate buildup, it leads me to believe that there is a deficiency in ornithine carbamoyl transferase. A deficiency in this enzyme would result in a buildup of carbamoyl phosphate due to the decreased rate of use in the reaction, while also leading to a lower but possibly still considered normal levels of citrulline. Now, I don't believe that levels of CPT1 are deficient, because if those levels were deficient, then the levels of carbamoyl phosphate would be much lower, because carbamoyl phosphate wouldn't even be produced, therefore orotate levels wouldn't be as high as they are as this patient is showing. And the fourth question for this part, my answer was due to the decreased rate of reaction in step 2 of the urea cycle and slightly lower levels of citrulline than recommended, an amino acid such as arginine, which is later in the cycle, would become essential as a result of this deficiency of ornithine carbamoyl transferase. Arginine is considered a non-essential amino acid, so our bodies do produce it, but in this case, the deficiency of products that are upstream of arginine would cause a deficiency in arginine, therefore causing the need for supplementation of this now essential amino acid. I will talk about case number 2. There are 3 scenarios in case number 2 to cover, and I will run through them one by one. So first, here's my answer for scenario number 1. When branched chain amino acids, or BCAAs, are positive in a screening test, it means that there is a deficiency in the metabolism of those BCAAs. And maple syrup urine disease is a disease that is caused by a deficiency in the oxidative decarboxylation of the metabolites of branched chain amino acids, which include leucine, isoleucine, and valine. And while I understand that there hasn't been a history of genetic disease and both older siblings are perfectly fine, I don't think that you can exclude this condition from presenting in this child, and there have been studies to show that. In fact, most children diagnosed with maple syrup urine disease are actually the first in their family to have the condition. So in maple syrup urine disease, the enzyme that is deficient is branched chain amino acid decarboxylase. I will now refer to that enzyme as BCAA decarboxylase. This means that all 3 branched chain amino acids cannot be metabolized. So leucine, isoleucine, and valine cannot be metabolized anymore because the enzyme that metabolizes them and pushes them forward in these reactions is deficient. Branched chain amino acids are already essential amino acids, so there's not a change in amino acids becoming essential or not essential through this deficiency. And while it has not been shown to work for every single person with MSUD, supplementing thiamine or vitamin B1 has been shown to improve the effects of MSUD in some patients. And that's because thiamine is a cofactor that is required by the enzyme that's deficient in this disease, which is BCAA decarboxylase. So without thiamine, the enzyme cannot move the reaction forward. So individuals with a deficiency in this enzyme they may not necessarily not have it completely, but what the addition of thiamine does is make the amount of enzyme that they do have even more efficient. So we encourage these patients to try taking thiamine as a supplement and assess how it may affect their MSUD symptoms. In scenario 2, it talks about an old woman with a lot of physical symptoms. And my answer to this reads, these symptoms correlate with a condition known as alkaptonuria. And alkaptonuria includes symptoms such as joint and bone problems, and these all start around the age of 30, which actually correlate with what she had said. She had said, well, she is a 69-year-old woman, and for the past 30 years, she's been having this pain that I'm about to mention that has to do with her joints and bones. So when she was in her 30s, if not her early 40s, she started to develop these problems, which correlates with the symptoms of alkaptonuria. And these symptoms include lower back pain, stiffness, knee, hip, and shoulder pain, and brown and gray spots on the eyes, as well as blue and gray ears that become thick and hard. And on top of that, the condition is also consistent with heart problems, such as heart disease and heart valve replacements. And these are all things that she clearly shows in her symptoms. So without further blood analysis or anything, it's pretty solid to say that she has alkaptonuria. So alkaptonuria is caused by a deficiency in the enzyme homogentisate oxidase, which is present in the tyrosine metabolic pathway. And deficiencies in this enzyme can lead to the buildup of both tyrosine and phenylalanine, because phenylalanine is converted and broken down through a tyrosine pathway, which cannot continue due to the lack of homogentisate oxidase enzyme. This deficiency doesn't cause tyrosine to become an essential amino acid because the production of tyrosine occurs before the deficient enzyme has a role in its metabolism. So tyrosine is being produced and created, it's just can't be used. So phenylalanine and tyrosine are both present in the body. Phenylalanine's product tyrosine simply cannot be further metabolized into fumarate or acetoacetate. There isn't much compelling research on vitamins or supplements that are effective at treating alkaptonuria long term, but it has been suggested that high doses of vitamin C may assist in relieving some of the homogentisic acid, and also with that, to assist in the pain that a lot of these patients feel, it's been recommended that the individuals try out physical therapy and see how that helps them. And in scenario number 3, we talk about a 4-day-old infant that has high phenylalanine levels. So due to high levels of phenylalanine, this infant may have phenylketonuria, or PKU. I will be referring to this as PKU from now on. So PKU is caused by a deficiency in either phenylalanine hydroxylase or BH4, which prevents the conversion of phenylalanine to tyrosine. So Since records didn't also report high levels of tryptophan, which also uses BH4 in that pathway, so since there aren't high levels of tryptophan, which would indicate BH4 or tryptophan hydroxylase deficiency, I would conclude that the deficiency in this infant is a deficiency of phenylalanine hydroxylase rather than a deficiency of BH4. Now, since tyrosine is made from phenylalanine through the assistance of phenylalanine hydroxylase, tyrosine will become an essential amino acid that will need to be supplemented into the diet. And past that, there aren't really significant supplements that would assist in the direct deficiency of phenylalanine hydroxylase, but since really the only thing that that's doing is producing tyrosine from phenylalanine, it's really imperative that tyrosine is supplemented into the diet for proper melanin, acetoacetate, and fumarate production. And that concludes my answers to these problems. Thank you very much.